So I'm Juan Bustillo. Most of you know me, and it is my pleasure today to introduce Dr. Rachel Rose. She's a third-year psychiatry resident in our program. She received her bachelor's in science and MD degrees here at UNM. While at the Residence Cope Clinic last fall, she approached Dr. Steve Lewis and I about the possibility of trying the new Xanomeline-Trospium medication for one of her patients. This drug had just been approved for the treatment of schizophrenia by the FDA days before she approached us. Dr. Lewis and I knew very little about this treatment. We had not used it. And Dr. Rose was the first physician in our department to use this drug. Since then, she has remained very interested in this new treatment. And she has become actually our local expert. I'm aware that the local representative of Bristol Myers, the maker of the medicine, has asked her to participate in other educational venues so far. So today it's a pleasure for me to introduce her, and she will share with us what she has learned about this novel treatment. Go ahead.
Thank you, Dr. Bustillo. All right, I'm going to share my slides. All right, can I get a thumbs up that you guys are seeing not my things? Thanks, Dr. Price. Okay, and can I get a thumbs up that everyone can hear me okay? Okay, thanks. So good afternoon, everyone. Welcome to Grand Rounds. I'm really excited to be here and incredibly honored. Like Dr. Bustillo had said, I had heard about Cobenfy being approved last year in September, and I thought, gosh, this is a point in my residency training that I'll remember forever, this new medication being out on the market. And I thought, this is so exciting, but I probably won't get the chance to use it for a while. And then fast forward like days, I think I was the first at UNM to prescribe it, and now I'm giving grand rounds. So things happen quickly, but just to say I'm honored to be here and also learning alongside all of you. All right, let me just make sure. Sweet. Okay. So our learning objectives today will be to understand the development timeline of Cobenfy, and we'll review the key clinical trials that led to its approval. We'll examine the mechanism of action and how it treats psychosis. And then we will also recognize clinical applications of Cobenfy thus far and how it's been utilized in a few cases. And I don't have any disclosures to report. Okay, so let's get started with a timeline of the drug's development and the key clinical trials that led to its approval. So our story starts here in the 1950s. This is a betel nut. It's chewed in Southeast Asian cultures. And inside the betel nut, there was found to be a natural muscarinic agonist, ericoline. And there was some preclinical studies done on ericoline exhibiting antipsychotic activity. So that's really where this whole story started. And then fast forward in 1997, this is probably the study some of you have heard about. But at this time, Eli Lilly makes Xanomeline, and they study it for the treatment of Alzheimer's disease. And they were actually studying it to treat cognition in Alzheimer's disease, and it worked. It helped with cognition. But there was an unexpected finding, which was that it also treated the behavioral disturbances associated with Alzheimer's. So this was paranoia, agitation, hallucinations, delusions. And it turns out Xanomeline is actually very structurally similar to ericoline. So at this point, it was like, maybe we're onto something. Maybe it can treat psychosis. And so in 2008, Xanomeline is studied for schizophrenia in a study of 20 patients, and it was found to be favorable in the sense that it treated psychosis. but the side effects were intolerable, both in this 2008 study and in this 1997 study. And we'll talk about what some of those side effects were, but at this point, Eli Lilly shelves the drug. In 2012, Karuna Therapeutics, brilliant. They say, okay, xanomeline was intolerable, but how can we make it more tolerable? Well, let's pair it with trospium, a muscarinic antagonist for overactive bladder. And I'll talk more about trospium later in this presentation. But Karuna Therapeutics calls this KarXT, and then they can start trials on its use in schizophrenia. And so in 2021, the emergent trials began, and you'll hear me say that quite a bit because this is the start of the key clinical trials. And emergent one, phase 2 trial, favorable, was showing to treat psychosis. So this moved to a phase 3 trial published in 2023 in the Lancet. And then emergent 3, the second phase 3 trial published in JAMA. Again, all of these publications were promising. So then they begin emergent 4 and 5, which is longitudinal data. And this is all presented to the FDA. And Bristol Myers Squibb owns now what is known as Cobenfy because they purchased Karuna Therapeutics. But these are the key clinical trials I'll be talking quite a bit about today. And so then September 2024, the FDA approves what we know now as Cobenfy. And so that's the timeline of how we got to where we're at today. And then I want to talk to you about these emergent trials. So emergent 2 and 3 are pretty synonymous. If you read one, it's like reading the other. So I'll be kind of using them interchangeably. But let's look at these studies. So they were both phase 3, placebo-controlled, randomized 5-week at inpatient sites across the US and Ukraine. And this was done in April of 21 to December of 22. The participants were adults aged 18 to 65. They had to have a DSM diagnosis of schizophrenia, and they had to be experiencing acute psychosis. So they all had baseline PANSS scores, and their baseline PANSS score had to be 80 or above, which reminder means markedly ill. But here is a really key point that I'll talk about much more in detail. But they excluded any patient from the study that was deemed treatment resistant. So anyone that had treatment resistant schizophrenia was not included in this study. And they hospitalized the patients and did a 2-week antipsychotic washout before starting them on Cobenfy. So hold on to that information as we carry through. Intervention. And so if you aren't familiar with Cobenfy, the dosing is 50 milligrams twice a day, 100 milligrams twice a day, or 125 twice a day. And so in the study, patients were randomized to placebo or Cobenfy. And the Cobenfy started at 50 BID twice a day, and then it was titrated to 100 and then up to the max dose of 125 if the psychiatrist felt like the patient needed that. And then for outcomes, so primary outcome, like all of our antipsychotic trials, was PANSS total score from baseline to 5 weeks, that change. But there was some really important secondary outcomes in the study that I'll talk about. And some of those are the positive and negative subscales, portion of patients reaching 30% reduction in PANSS. And we'll talk about those secondary outcomes as well. And so what happened? What did they find? Well, here is the graph that I pulled straight from JAMA. Here's our primary outcome of PANSS total score. And you see placebo in blue and Cobenfy in orange. On your x-axis, you're looking at baseline to 5 weeks. So that was the length of our study here. And then on the y-axis, you're looking at the least square means change. And essentially, this is the change in PANSS total score. This is a statistical model that adjusts for a lot of confounding variables. And this is how a lot of antipsychotic trials report PANSS changes. So if we look at this orange line, what you see, those little letters indicate significance. So Cobenfy separates from placebo at week 2, reaches statistical significance, and that carries forward through all of the study, all of the 5 weeks. It separates from placebo. So at the end of 5 weeks, PANSS total score about a little over 20-point change in our intervention group of Cobenfy versus about 12 in placebo. So now let's look at some of those secondary outcomes. So the PANSS positive subscale score. And this is important, right? Because like when we're inpatient, we're using our antipsychotics, we're monitoring positive symptoms more than anything. So what did it do for our positive symptoms? Well, again, orienting you, you're seeing pulled straight from JAMA, Cobenfy in orange, placebo in blue. And we're looking at x-axis the time of the trial, y-axis, we're reporting the change in the positive subscale score. And again, those letters indicating statistical significance. So at week 2 through week 5, placebo, Cobenfy separates from placebo in terms of what it's doing for positive symptoms of schizophrenia. And I'm adding here the smaller graph on the bottom right. This is pooled data. So this is straight from Cobenfy's website. And this is for the PANSS positive subscale score. And this is pooled data across all of the emergent trials. And I wanted to put this here just to really highlight, it wasn't just this one trial. All of the pooled data showed a very similar trend in terms of total and positive subscale score. So by the end of the 5 weeks, when you look at all of the emergent trial participants, they almost had a double reduction in their positive subscale score. This is promising. And so let's keep looking at more of the secondary outcomes. So one of the other secondary outcomes was greater than or equal to 30% reduction from baseline to week 5 in the PANSS total score. And this is oftentimes reported in antipsychotic trials because this is what's been agreed upon as being clinically significant, clinically meaningful. So it's essentially saying what portion of patients had a clinically meaningful reduction in their PANSS total score. And let's see what happened here. So you're looking at emergent 2 on the left and emergent 3 on the right. X-axis, you're seeing the weeks of the trial, and y-axis, you're seeing the portion of the percentage of participants that met the secondary outcome criteria. And really what I want to highlight here, both of them look very similar, is that so by the end of 5 weeks, essentially half, if not a little bit more, of patients who were on Cobenfy had a clinically meaningful reduction in their PANSS score versus 25-ish% in placebo. So again, this is promising. Even these secondary outcomes are showing us, you know, that this is favorable. Continuing with our theme of secondary outcomes, let's look at the PANSS negative subscale score. So we looked at the positive, it was favorable. What about negative? So again, you're looking at a very similar graph, Cobenfy's in orange. So in general, when you look at it, negative symptoms decreased, and it actually only reached significance on week 5. Simultaneously, placebo had a bump in that week, so that's probably what explains that significance. But I've put this icon here at the top right of the graph to remind us to be critical appraisers of this data. So I want to kind of draw attention to this idea of primary negative symptoms versus secondary negative symptoms. So primary negative symptoms are intrinsic to the pathophysiology of schizophrenia. They are a direct result of the disease itself. Now, there's secondary negative symptoms, for instance, anhedonia, social withdrawal, that are due to external factors and might even be due to the positive symptoms themselves. So for instance, if you have a patient who is incredibly paranoid and does not want to come out of their room, that might look like them being asocial, or maybe they're really fearful and they don't want to do anything, and that might look like anhedonia. Or maybe we've Parkinsonized them with Haldol and then their affect is flat. So those are all secondary negative symptoms that are attributable to something else. And in a study, when we're treating positive symptoms, we would imagine that the negative symptoms would improve as we treat the positive symptoms. And also a reminder, the PANSS negative subscale, if you haven't had a chance to look at it, it's 7 items, and it's not just assessing for primary negative symptoms. That's a clinical judgment. You can't make that just based off the PANSS score. And it really can't delineate primary versus secondary negative symptoms. There's even questions on there about disorganization. And so in a study, when we're treating positive symptoms, we really can't extrapolate much from this data in terms of negative symptoms. Okay. So when I when I went through the emergent trials and seeing all this data, like the question that comes to mind for me is like, okay, this is really great, and this is, you know, this looks like it's super favorable, but how does it stack up to what we have? What's the difference between our current, you know, standard of care? And so how does Cobenfy compare to other antipsychotics is really the question. And what I've done here is I've pulled, so our most recent approved second generation antipsychotic, lumateperone on the left. I pulled this straight from the trial they presented to the FDA. And again, very similar. You're looking at the PANSS positive symptom subscale with your trial on the bottom, least square means change reported on your y-axis. And really just point here, if you're looking lumateperone, and I put Cobenfy over there on the right so you can see side by side. They separate in placebo in very similar ways, reaches significance, that significance carries on. Now, to make a point here, we cannot compare Cobenfy and lumateperone. We would need a head-to-head trial. But the way that they've separated from placebo and reached statistical significance is similar. And so taking this a step further, what about lumateperone? So in 2019, the Lancet put out this great paper where they compared efficacy and tolerability of 32 oral antipsychotics. And from this paper, I was able to extrapolate effect sizes. And the effect size of the emergent trials was 0.6. And so you're seeing here, 0.6 is like right up there with olanzapine, risperidone. So it's pretty good. And a 0.6 effect size means this is, you know, clinically significant. And so again, I can't draw comparisons of Cobenfy versus all of the ones that I have listed here, but the way that they separate from placebo, the effect size seems like it's right there with our current standard of care. Okay. So now I'm going to transition to Emergent 4, which is a 52-week open label extension of the Emergent 2 and 3 data. And this is important because a 5-week trial, great, there was improvement, positive symptoms improved. But really what we want to know is like what happens long term with our patients. And so this was pulled straight from Cobenfy's website. What you're seeing on the left is the 5-week Emergent 2 and Emergent 3 trial. And then the 52-week open label extension. You're looking at the PANSS total score, again, change from baseline. And big points here, like big takeaways from this open label extension. We see this continued PANSS positive and total subscale improvement. So the improvement you saw in the first 5 weeks is sustained. Patients continue to get better. Cobenfy generally safe and well tolerated. We'll talk more about that in a bit. And this is a big one, not associated with metabolic syndrome and EPS. And again, I'll talk about this because when's the last time you heard someone say that their antipsychotic wasn't associated with EPS and metabolic syndrome? And then another thing is that a large portion of the patients had achieved that 30% reduction in PANSS. So again, large portion making clinically significant or clinically meaningful improvements. Okay. So you might be asking, well, you told me at the start of this presentation that in 1997, they studied it for cognition and Alzheimer's disease and it worked. So what about cognition? And I was preparing this grand rounds and I went to my mailbox last month and I got my American Journal of Psychiatry out of the mail. And sure enough, front cover is Cobenfy improves cognition. And so I'm excited that I got that in time to be able to share it with you all today. And so in the original emergent trials, there wasn't much noted about cognition, but it turns out they had something brewing all along. So in the emergent and 2 participants, what they had done in those initial trials was they had administered cognitive assessments at baseline, week 3, and week 5. And they used the CANTAB cognitive battery, which stands for Cambridge Neuropsychological Test Automated Battery. Had to cheat on that one. And they wanted to essentially see if patients in the emergent trial had improved cognition. And so you're looking at 2 graphs here. Over here on the left, and that's where I want you to look first, is the pooled sample. So of all the emergent 2 and 3 patients, you're seeing there's the x-axis baseline to week 5, and on the y-axis, you're seeing change in the cognitive battery. It did not reach statistical significance. So looking at the pooled sample of emergent people, can't say that Cobenfy helped cognition. Now, here's the interesting thing. The researchers then took a subgroup of these participants, and they were considered impaired, meaning they were one or less than one standard deviation below the norm at baseline, and they were considered impaired. And if you looked at that impaired subgroup and then looked at the cognitive testing, they actually had a statistically significant, meaningful change. And so their cognition had improved. And one of the key parts about this is that their cognition improved. They had adjusted for the improvement in positive symptoms. So their cognition improved regardless of the improvement in positive symptoms. And so now over here on the left, what you're looking at is the different subtests they did. And this is important because, you know, the question that came to mind is like, okay, what about their cognition improved? And so down here on the x-axis, you're looking at 4 of the subtests they administered. And the one-touch stockings of Cambridge is actually a measure of executive functioning. The spatial span test is a measure of visual memory. The verbal recognition is a study of verbal recall and recognition. And then rapid visual information processing is measuring sustained attention. So essentially on executive functioning, verbal recall, and sustained attention, we reach significance in the impaired subgroup only. Of note, placebo here, don't really know what to make of this. But big thing here, executive functioning, there was statistical significant improvement. Now, you might recognize my little icon here about being critical appraisers of the data. So this is great, and this is reassuring, but this was done on inpatient participants who were experiencing acute psychosis. And so this is not generalizable to all of our patients in the outpatient setting. And so if you're wondering, well, should I just start my patient who has cognitive impairment on Cobenfy just to help cognition? The answer is, I don't know yet. We would need a well-controlled trial on stable patients in the outpatient setting before we can really draw conclusions about its help in cognition based off this sample. Okay, I'm going to transition into mechanism of action. So we'll talk about xanomeline. This is a selective muscarinic M1, M4 agonist. Now, a helpful way to think about xanomeline is what does peripheral M1, M4 agonism do? And this really explains our side effects. And what does central M1, M4 agonism do, i.e. how does it treat psychosis? And so we'll start with the peripheral agonism first. And so in comes our parasympathetic nervous system. Our parasympathetic nervous system acts by releasing acetylcholine, which activates muscarinic receptors on target organs. And those organs include cardiac muscle, smooth muscle, your GI system. And so when we have xanomeline pushing on our parasympathetic gas, it's intolerable. And this is why in those initial studies, Eli Lilly shelved the drug because patients were experiencing vomiting, diarrhea, salivation. It was incredibly uncomfortable and intolerable. So that's why Karuna Therapeutics says, okay, well, what if we make it more tolerable by counteracting some of that peripheral muscarinic agonism and pair it with trospium, the muscarinic antagonist for overactive bladder. Now, here's the cool thing about trospium. It does not cross the blood-brain barrier. So you are able to counteract some of this peripheral M1, M4 agonism without trospium getting into the CNS and counteracting what xanomeline is doing for psychosis. And so super brilliant, but like all things in medicine, our body wants to maintain homeostasis, and now we're pressing on xanomeline's pressing on the parasympathetic muscarinic gas, trospium's pressing on the brake. And so we try to create the balance, but the balance always tips. And so that's why some of the side effects that we'll look at here in a sec are actually like constipation, more of a sympathetic type thing, or still diarrhea, still vomiting, more of a parasympathetic thing. So again, that's kind of where we're trying to create this balance, which doesn't always work. And so what are those side effects? Well, I've already said some of them, but here is the pooled data from the emergent trials. And really, you'll see most frequently reported side effects, the nausea, dyspepsia, constipation, vomiting. And actually, Cobenfy had their studies had looked at the nausea and vomiting in particular. And really, we see here gets worse in the first couple of weeks and then tends to get better. So if you're prescribing Cobenfy, I would really recommend telling your patients like, hey, just try to push through the first couple of weeks. It's going to be uncomfortable, but most people get better. And the data clearly shows that. And in the trial and in real life, Zofran's our friend. And so obviously watch your QTCs, but Zofran helped in the trial and it helped with my patients on Cobenfy. And something we're not used to with our medications is that eating around the time of taking Cobenfy actually speeds xanomeline's absorption and makes the nausea vomiting worse. So the package insert says not to eat an hour before or now 2 hours after taking Cobenfy. So really stay away from food. And what I really want to draw your attention to is down here at the bottom of the side effect profile. So, let me go back, sorry. We see down here at the bottom, EPS, non-akathisia. Again, since when is EPS at the bottom? Least reported side effect of an antipsychotic. So this is really incredible and like what I really want you to take away from today, that there was very rarely any sort of EPS reported. There was no metabolic syndrome side effects reported. And in fact, there's no boxed warnings on Cobenfy about metabolic syndromes or tardive dyskinesia. This EPS that they had included here, gosh, sorry, I keep doing that, had included dystonias, involuntary movements, muscle contractions, dyskinesias, drooling. So really a whole gamut of things that we're not used to being lowest on the list. Okay, so we've talked through the peripheral M1, M4 agonism and how that leads to the common side effects. And now let's get into the good stuff. How does it treat psychosis? And so we're going to be focusing on central M1, M4 agonism. Okay, so where are M1, M4 receptors in our brain? That's important to know. Where is this drug working its magic? And so M1 receptor expression, heavy in your prefrontal cortex. M4 receptor expression, heavier in your subcortical regions. And so we'll be talking about the prefrontal cortex versus subcortical regions. So let's start with M1. And again, these are all proposed mechanisms of action. These are kind of like what the running hypotheses are right now. So let me orient you. You are looking at the prefrontal cortex. And what you're seeing there is that the prefrontal cortex sends excitatory glutamatergic signaling downstream to the ventral tegmental area in the midbrain, where a lot of dopaminergic neurons live. And so in your prefrontal cortex, when you're sending that excitatory glutamate signaling downstream, you're getting release of dopamine in the midbrain. Now, in your prefrontal cortex lives these inhibitory GABAergic interneurons. You see them right there in panel A and layer 2. And on those interneurons live the M1 receptor. And so when xanomeline acts on the M1 receptor, you get an increase in this GABA firing, which is inhibitory. It synapses on this glutamatergic neuron. You get less of the glutamate signaling downstream, and thus your VTA dopaminergic neurons will fire at a decreased rate. And so essentially, this is a fancy way of showing top-down processing or top-down dopaminergic modulation via the muscarinic receptors. And now let's transition to the M4 receptors. So orienting you down at the bottom of the picture, this is your LDT, or your lateral dorsotegmental nucleus. This sends cholinergic neurons, or cholinergic projections up to the VTA in your midbrain. And then your VTA sends dopaminergic signaling to your nucleus accumbens. And so if you look at panel A here, you're seeing that cholinergic afferent coming from the LDT, synapsing in the VTA. And on this cholinergic afferent lives the M4 receptor. And now the M4 receptor is an autoreceptor. So when xanomeline acts on M4, you actually get decreased release of acetylcholine. And so decreased release of acetylcholine in that cleft decreases the VTA dopaminergic excitability and firing. And so then, jumping over to panel B, you have less of that dopaminergic firing coming in the nucleus accumbens. There's less signaling. Now, simultaneously in the nucleus accumbens lives cholinergic interneurons, and on those cholinergic interneurons are more M4 receptors that again are autoreceptors. So when activated, there's decreased acetylcholine release and then decreased dopaminergic firing within the nucleus accumbens. And so taking a step back, this is more of a bottom-up processing. So how are cholinergic interneurons or synapses modulating dopamine from a bottom-up standpoint? And all of this really, like all of these proposed mechanisms, are essentially just decreasing dopamine firing and signaling, kind of decreasing the dopaminergic tone in our brain indirectly through these acetylcholine synapses. Now, this is very different than just direct D2 blockade that we're used to for most of our antipsychotics. And to say too, clozapine, we all know clozapine has some of this M4 agonism as well. And that's also believed to be what makes clozapine one of the best. Okay, so now I'm going to transition into some case reviews. And so this is my first patient. I got to start on Cobenfy. He's a young male in his 20s. He was previously at CPH and then came to me in Cope. He's had many previous hospitalizations for decompensated psychosis. He has schizophrenia and MDD. He's been on trial on tons of antipsychotics, all with pretty significant side effect intolerance. He is higher functioning. He attends fine arts classes at UNM. He lives independently. But when he saw me, he was still having ongoing derogatory auditory hallucinations. He was describing some ideas of reference, like he'd be driving to school and he'd hear a song play and he'd think that the song was about him, and it would take him quite a while to snap out of it. And he also just had kind of hyper-religious themes that sometimes blurred the lines of being delusional. So anyway, at that point, when I saw him, he was on ziprasidone 80 total daily dose. And previously he'd been trialed on higher ziprasidone, but it caused akathisia. So we were kind of just in this like holding pattern. He also was on Buspar and Prozac. So I want to show you something that's pretty stark when I saw it, and that is his BMI growth curve. And so when we're talking about, or his BMI curve, when we're talking about metabolic syndromes, here is like classic example. So I want to draw your attention down there when he really starts to come up in his BMI, and it probably wouldn't surprise any of you to know this is when he started his first olanzapine trial. And he just climbed. And even when I saw him, he's like, I just can't lose weight. Even though he was on ziprasidone, more weight neutral. And then if you look there at the start of 2025, he loses some weight. He's bounced back just a little bit, but he's kind of started to really lose weight. And I'll tell you, this is when we started him on Cobenfy. So, but let me tell you how we did this. Like, how did we switch him? So his story is interesting. We started with the Cobenfy starter pack. And if you don't know, the Cobenfy starter pack has 50 milligrams BID for 2 days, and then it jumps you up to 100 milligrams for the rest of the month. Now, remember, you could go max of 125. So he started on the starter pack, and we continued his ziprasidone. All I knew at that time was, I just want Cobenfy to be at steady state before I begin tapering. He calls me a week later. He has significant nausea and vomiting. I mean, I called him, and on the phone, he was like vomiting. So I prescribed him Zofran, but he was a trooper. He really wanted to stick it out. Now, at this time, he tells me, well, Dr. Rose, you told me not to eat with Cobenfy, but you also told me I should be eating to absorb my ziprasidone. So which is it? And then at that point, I'm like, oh, shoot, this is a real problem and you're really sick. So let's start tapering ziprasidone pretty quickly, which we did. We got him off the ziprasidone. His nausea and vomiting improved. He did have a significant daytime headache, which we did a bunch of troubleshooting, like is it dehydration, all these other things, and he was pretty certain it was the Cobenfy. Simultaneously at this time, um, I realized that he's on Prozac, which is a 2D6 inhibitor of the CYP P450 enzymes in our liver. And Cobenfy is metabolized through 2D6. And so at this point, I realized, shoot, he's probably been on super therapeutic levels of Cobenfy this whole time, and this might be why he's so sick. So I DC'd his Prozac, and reminding you, Prozac has a long half-life, its metabolite has a longer half-life, so it's sticking around for a while. Started him on Lexapro. And because of this headache, he wanted to try 200 QHS dosing, which I thought, okay, that's not how the study's done, but there's a lot of our antipsychotics that are supposed to be BID that we do QHS, so I think it's worth trying. He absolutely could not tolerate that, had significant night sweats and insomnia. So he requested to just move to 100 QHS at night. And that's where he's been for the last couple months, actually longer than a couple months. And so I saw him 2 weeks ago, and I'll tell you that right now, his mom says that he is the best he's looked in 6 years. He still has some intermittent ideas of reference. Um, Interestingly, his mood is a lot better, and he says that he's thinking more clearly than he ever has. In general, he's very happy with where he's at and feels like this is the best that he's been. And so, this case brought up a lot of great considerations that I wanted to share with you all. And the first is cross tapering of antipsychotics. I wish I could be presenting this to you all and say this is how you cross taper, but there's really no specific guidelines out yet. For me, I wanted Cobenfy to be at steady state before starting to taper his antipsychotic. The Cobenfy specialist who I talked to a lot has told me that in the community, they're seeing a lot more use as dual agent therapy than monotherapy. And it makes me wonder if it's because we just quite don't know how to cross taper yet, or maybe we're too worried about it. The other consideration is like, what antipsychotic is your patient on? If they are on highly anticholinergic antipsychotics like olanzapine, maybe clozapine, Seroquel, is that going to be counteracting the xanomeline? And clozapine brings up special considerations given that it also has highly anticholinergic, but also M4 agonism. So it's still I don't have a great guideline to give you guys. I really wish I did. The next consideration here is the CYP2D6. And so this is straight from Cobenfy's package insert. Strong CYP2D6 inhibitors like our friends Prozac, bupropion, Zoloft, duloxetine, Paxil, they will inhibit Cobenfy's metabolism and raise Cobenfy's blood levels. And lastly, the nausea, vomiting, eating restrictions. And so here's your power chart order, just reminding you, you really shouldn't be eating around it. And I draw attention to this because, telling your patients to take their lorazepam, ziprasidone, SSRIs with food would really be difficult for patients and really contribute to their nausea and vomiting. And so I would be curious to know if anyone in the audience has used Cobenfy yet, and maybe put it in the chat. I'm going to just share some brief cases I've tried to gather of those that have used it thus far, and kind of a range of the outcomes. So this is my second patient I started on Cobenfy. She was in her 60s, severe treatment-resistant schizophrenia. She's done ECT this year, and it didn't really help. She got way too sedated on clozapine, like couldn't even drive her car. So I DC'd all of her antipsychotics, started her on Cobenfy. I wanted to move slower with her titration because of her side effect sensitivities. She ended up developing severe urinary retention, And I'll tell you, she did not have urinary retention prior. She's doing okay now, but urinary retention is a contraindication to Cobenfy. It's one of the few. And so thinking about a female in her 60s who develops urinary retention, I was like, oh gosh, please don't get delirium. This is a recipe for delirium. And so we have to be really careful with those side effects. This is interesting. So the Cobenfy specialist had told me about a patient in southern New Mexico who had really great response to Cobenfy. So I reached out to the provider down there and we chatted about his patient. So he's a male. He's had years of severe treatment-resistant schizophrenia. Like they've so severe, like his paranoia, very isolative, doesn't leave his house. When he needed clozapine blood draws, one particular EMS employee would come to his house and gather the blood draws weekly. That's how paranoid he was. So they discontinued all of his antipsychotics, started him on Cobenfy. He's now been on 125 BID for 6 months. And although he's still psychotic, his paranoia has improved to the point of him being able to go to church, which is huge for the family. So, you know, in the sense of quality of life, really big turnaround for this patient. A colleague of mine in Cope Clinic has a male in his 30s, chronic schizophrenia, hyper-religious delusions. He's had side effect intolerance. He was on risperidone. They switched him to Cobenfy 100 BID for the last couple months. Very similar to my patient, noting the cognitive effects, feeling sharper, similar to my patient, mood improved, psychosis has had mild improvement. And then lastly, I'll share this one, a patient, I'm at the VA now, and a patient here in his 70s currently admitted treatment-resistant schizoaffective disorder. We've done everything for months for him. He could not tolerate clozapine. So we tried Cobenfy without any improvement. Now, it didn't cause orthostasis, which the clozapine did, so that's good, but it did not help with his psychosis. And so I chose these cases because they kind of outline different, really just the different outcomes we're seeing in the clinical setting. And so I want to just touch on the gaps here and the questions that we still have about Cobenfy. So treatment-resistant psychosis, I've said it a lot throughout this presentation, and I'll say it one more time. The study excluded patients with treatment-resistant schizophrenia. And especially here at UNM, we're treating a lot of sick patients and patients with treatment-resistant schizophrenia. So Cobenfy does not have approval for treatment resistance. It doesn't mean you shouldn't try it. We saw the patient in southern New Mexico who's had success with it. It just means we might be applying it in places that the data didn't support. Antipsychotic cross tapers, we still don't know. I think this is a huge question mark, and so I would say just be careful about your CYP inhibitors and be careful about anticholinergics they might already be on. Special populations. And so first I'll talk about first break patients. And I'm thinking, gosh, you know, if I have a first break patient in his early 20s, he's never tried an antipsychotic before, and I could choose Cobenfy and not expose him to the risk of tardive dyskinesia or metabolic syndrome for the rest of his life, I feel like I'd be reaching for it. Now, the caveat there is a lot of the insurances, which I'll talk about in a second, womp womp, incomes insurance, they might not approve it if it's not, you know, if others haven't been tried and failed. So I don't know. Our geriatric population, I hinted at it with my lady in her 60s who developed urinary retention, but some of these side effects, urinary retention, constipation, we need to be really careful because that could cause delirium. Primary negative symptom improvement, I touched on this, but we really can't draw conclusions about negative symptom improvement based off the emergent trials alone. We really just can't delineate using the PANSS subscale what negative symptoms were being treated and if it wasn't a direct result of the positive symptom improvement. Cognitive improvements, I touched on this as well. So first, thinking about our geriatric population, maybe it would help with cognition, but also, again, these were sick patients on inpatient units doing these cognitive batteries. This is not your outpatient panel. And then varying diagnoses. I mean, a lot of our antipsychotics at this point have D2 blockade. We know that D2 blockade has anti-manic and mood stabilizing properties. So would Cobenfy work for mood stabilization? To be determined. I'm going to finish with just a few slides on logistics. So you can order it through PowerChart. It's not a miscellaneous medication. Just type in Xanomeline, here are your doses. Reminding you about the starter pack option. And I've put a question mark here because maybe you want to move a little bit slower if your patient has side effect sensitivities. Now, I will say, interestingly, for my patient, his insurance approved Cobenfy, but it was a $90 copay. And so I did the starter pack because I didn't want him to have to pay $90 for the 50 milligrams for a couple weeks and then $90 again for 100 milligrams. And so we just went for the starter pack. Now, in retrospect, I probably would have gone a little bit slower. And then prior authorizations, our favorite, but I've had success with Cover My Meds. That's how my two patients got it. And speaking of prior authorizations, here's a QR code. If you haven't had the chance to just peruse Cobenfy's website, it's really good. They have a physicians tab, and then they have a patients tab. I told my patients before starting Cobenfy, like, please look at the website. It does a really good job of breaking down side effects. It even has this Cobenfy Cares, where if you're being prescribed Cobenfy, you can be part of this Cares program and you can like reach out to providers or specialists. But on the providers page, they have these really great downloadable resources. So like a letter of authorization, they have information on Medicaid. I've asked one of the Cobenfy specialists who does all the insurances if she could provide me with a list of what insurances are covering it and if it has to be, you know, it could be first line, second line. And she was like, oh gosh, if only. So it's kind of just hit or miss. And so, but they're really, I think the kind of what I've been hearing is that it's getting easier, and I hope it would. And so with that, I will stop sharing. And look at my chats. And I will take any questions for any of you that have any questions.
Well, while everybody's thinking of questions, let me just ask Dr. Rose. So, in terms of you said the drug has a very good profile in terms of EPS and metabolic syndrome. Is there evidence for that in terms of long-term follow-up, not just 5-week follow-up?
Yeah, so that's a great question. So in the 52-week open label extension trial, they had seen similar effects in the sense of no weight gain, no evidence of any sort of EPS. And so there's, like I had said, there's actually nothing in the package insert about warning about TD or metabolic syndrome. And then I see, how much is Cobenfy out of pocket versus insured generally? Would insurance be more willing to pay for generics? Are they cheaper? So, gosh, I wish I had the answer for you. I can tell you that one of my patients on Medicaid had a $0 copay. My other had a $90 copay. I do not know how much it is out of pocket. Okay, so this is seeing a patient on Cobenfy max dose, which wasn't enough to cover her positive symptoms. We added cariprazine, which seems to have made her symptoms tolerable. However, the side effect burden is improved. She's very sensitive to both EPS and orthostatic side effects from other antipsychotics, seems to be tolerating this combo well. This was a patient that seemed like she would never tolerate a max dose. That's awesome. That's really cool. Yeah, again, with this dual therapy. Dominique, I see, or Dr. Price, I see your hand up.
Oh my gosh, what a great presentation, Dr. Rose.
Thank you.
Really, really wonderful. So I just wanted to clarify. And so with Cobenfy and this lack of EPS, am I remembering? So this is, my guess would be that it's because it is not affecting dopaminergic signaling in specifically the it's only
Nigrostriatal
yeah,
pathway.
it's only affecting in the VTA and the frontal part of the brain. And so that's why we're not seeing EPS at all.
That is my understanding.
Okay.
Yeah, so you're not really blocking the dopaminergic signaling right in the nigrostriatal pathway. Um, generally decreasing dopaminergic tone, I would wonder if there would be some sort of subsequent movement, but I don't know. But yeah, that's my understanding as well.
And then I'd be curious to see if like long term it affects sort of dopaminergic expression in those areas of the brain, since it's sort of this secondary modulation of signaling. But my guess is we're not there yet. I
Yeah.
I had a quick other question, like, do you know if they're doing studies on sort of mood stabilization properties?
Yeah, that's a good question. I don't know. I should ask because I would be curious to know like what they're doing now. I think the cognition was like the next piece, and then, but yeah, the mood stabilization would be fascinating. Hi, Dr. Ortiz.
Thank you so much, Dr. Rose. That was a great presentation. So when you were talking about the effect sizes, you put Cobenfy in between olanzapine and clozapine.
Mm-hmm.
How do you think this is the true effect size? Or, and if it is, what is it that, why do you think the companies are not giving us a head-to-head? Because if they were very confident of this larger effect size compared to the other antipsychotics, they will give us a head-to-head. But I don't think they are planning on doing that. So I wonder if you have any thoughts of if this is a true elevation of the effects, or it's just, I mean, I suspect that it's an artifact of this enriched sample for severity. That is, they discontinued the antipsychotics, they did the withdrawal of the antipsychotics, they get sick, and then you start them, and then it makes your drug look a little bit better. So I just wonder if you have comments about that.
Yeah, no, and that's why the med washout is such a key part of this, right? Like they had the ability to hospitalize their patients, make sure they were safe, take them off their medications. They're 2 weeks psychotic, very psychotic, not on any meds, and then you give them this antipsychotic. The results are probably going to look pretty good, right? So I agree. I showed that effect size there, but yeah, I don't think we can say like, hey, use it, it works as well as, it's almost as good as close it. No way. Just kind of an idea of what the original trials showed, but I would love a head-to-head. That would be really nice.
I just came from the schizophrenia conference, and I mean, obviously this was very important in the schizophrenia conference, and I don't think they're gonna give us a head-to-head, because it will, what if it doesn't show that? I mean, they already have it approved. What if it shows that it's inferior to other antipsychotics? And so I mean, unless this is not pharmaceutically driven, I think it's very unlikely that we're gonna see a head-to-head in the short term.
Yeah, that makes sense.
Yeah, let me add a comment on what Javier said. So I don't think that the effect size that you showed, Rachel, was really larger than most of the other antipsychotics. I mean, it was up there with olanzapine and risperidone, but it wasn't as high as clozapine. But that's really mixing apples and oranges, because of course clozapine is only used for treatment-resistant schizophrenia, and so the effect size compared to the contrast medication, typically chlorpromazine, is much bigger for clozapine. So I'm not that concerned that Cobenfy is sort of inflated. It's artificially inflated its effect size because of design characteristics.
Yeah, that's a great point. Hi, Dr. Toan.
Yeah, just first of all, great presentation, Dr. Rose.
Thank you.
Just a comment. I think a key thing here is that the new mechanism of action. So if the effect size, someone will do a head-to-head, which would be good. But I think the most valuable thing here is a new mechanism of action, which means that the drugs that we have now, they're all Me Too. They're very similar. So I think that's what's the most valuable about this medication. And thank you again, Dr. Rose, for educating us about this new treatment.
Yeah.
I keep thinking about what you said about people in the community too using like augmenting with it. And so I will be curious. It seems like there just aren't that many studies sort of looking at it in conjunction with other antipsychotics. And so I'd be curious, since the downstream mechanism is the same, target goal is sort of the same, if you're going to, how well augmenting with it would actually work.
Yeah, I kind of have been thinking about Cobenfy more so like it's just kind of generally decreasing dopaminergic tone. And it does kind of raise the question, Dr. Escalona and I have talked a lot about this. If you're blocking, your D2 receptors with antipsychotics that are already out, and then you add Cobenfy and you're kind of just decreasing the tone, does it make the receptors more sensitive? It's just, it brings up a lot of questions.
Any other questions? Still have a couple minutes. Comments?
Hey, this is Will. I'm in a somewhat crowded room at the VA, so we're having a little side discussion. I was curious if there's any indication that using Cobenfy in conjunction with more classic D2 antagonists might actually worsen some EPS, since then you have both upstream downregulation and blockade at the receptor.
Right. Yeah. I don't know the answer to that, but that's something that Dr. Escalona and I have talked about. If you're decreasing the dopaminergic tone and then you're blocking it, and then, experiencing tardive, that then all of a sudden the receptors become super sensitive. Yeah. I don't think, at least from what I've heard kind of from the specialists in the community, I haven't seen that yet. And I think Dr. Bustillo has some patients on Cobenfy and other antipsychotics, but yeah.
Any other questions? All right, well, let's just end here. And thank you very much, Dr. Rose, for a wonderful presentation.
Thank you.